All right, welcome everybody to COVID-19 and FDMAS. This is an updated conversation. We are recording this and streaming to Facebook. We'll share the recording afterwards if anything should happen to our live stream, though we hope that it doesn't. My name is Tova Burstein. I'm the Community Engagement Director with the FDMAS Alliance. And I am joined here today with our wonderful panel of speakers. We have Dr. Alison Boyce, Chief Metabolic Bone Disorders Unit of the National Institute of Dental and Craniofacial Research at the NIH. She's also our Medical Advisory Council Chair. Dr. Michael Collins, the Senior Investigator in the Skeletal Disorders and Mineral Homeostasis section of National Institute of Dental and Craniofacial Research. He served as the FDMAS Alliance's Medical Advisory Chair for over a decade and is currently acting as our Scientific Advisory Chair. Dr. Edward Hsiao, Associate Professor of Endocrinology and Metabolism in the UCSF Metabolic Bone Clinic, as well as the Director of UCSF's Diabetes, Endocrinology, and Metabolism Fellowship Program. And Dr. Kelly Wentworth, Assistant Adjunct Professor of Medicine, Division of Endocrinology, Metabolism, and Diabetes at Zuckerberg San Francisco General Hospital at the University of California, San Francisco. And she's also the recipient of a 2018 Team FDMAS $1 Million Bike Ride Award. And we hope to be joined soon by Dr. Robert Stanton, who is the orthopedic surgeon with Nemours Children's Hospital of Orlando and a longtime advisor and collaborator of the Alliance. He's also the most recent recipient of our Constellation Award. He is currently in surgery. So again, we hope to have him join as soon as he's able. We're holding this conversation just about a year after our previous conversation, just to answer some questions, bring some clarity to this community, the FDMAS community, in regards to COVID-19. And thought we'd start today with simply going around with our panel and sharing what care and research looks like right now at your institutions. Perhaps we can start with the folks at the NIH.
Sure, we're happy.
Alison, you can start and you speak for both of us. So.
Well, know about that. Sure, yeah, there's been a lot of developments over the past year. I think at the last time that we had this conversation, it was very early in the pandemic, and a lot of things were getting shut down. The lockdowns were quite tight, and we were seeing very few patients for research and as well as for clinical care. In the interim, I think we've learned a lot about how COVID spreads and what situations have more or less risk of spreading the infection. So we've opened up quite a bit with regards to our clinical care. Patients who come to NIHs for their primary medical care are able to come. There have not been interruptions in routine medical visits, routine imaging and labs, things like that. We still have a number of restrictions for research patients and specifically related to travel. So a number of our patients live all over the country and all over the world. So air travel has been very difficult during the pandemic. We've prioritized trying to keep trials open that involve treatments so that patients aren't denied kind of experimental medications and other treatments. But it has been difficult. At this point, restrictions are easing a bit for patients who travel who are vaccinated. So I think the introduction of the vaccines is hopefully going to have a big impact on our ability to move forward with some of our research programs. Anything to add to that, Mike?
No, that covered it for us.
Mm-hmm.
And how about on the West Coast at UCSF?
Yeah, thanks, Tova. So at UCSF, I mean, California, unfortunately, has been pretty hard hit with COVID. And we've been pretty lucky at San Francisco. And I think San Francisco's been pretty strict about the management of COVID, with masks and with other restrictions. And this has actually made a huge difference. There's been a significant prevention of spread, and the hospitals actually have not been particularly overwhelmed. So that really does, to us, show that these types of measures can have very significant benefits. I think from a clinical standpoint, I think We have transitioned pretty much all to telemedicine. There have been a lot of patients who follow up with us on a regular basis, and so that provides a great way of maintaining continuity of care and helping to make sure that things are not missed or falling behind. For many of the visits, there were decreased numbers of in-person visits that occurred on site, but that is now picking back up. Patients are definitely allowed to come in, and the hospital is open. Everything is still, is actually going pretty well for in-person visits. And I think the other important thing is that the hospitals, not just ours, but I know across the country, have really implemented a lot of different safety measures. And so those include, universal masking and very conscientious cleaning. And so that has really prevented any sort of spread, within the hospital system. And I think that is one of the things to emphasize is that we're able to see patients, we're able to help with the continuity of care, and really make sure that things are going well from that standpoint. I'll have Kelly talk a little bit about how our research has been impacted.
Sure. So as Dr. Boyce had mentioned in the beginning, the restrictions were, quite significant. And from the lab-based research standpoint, it was challenging in the beginning. The lab was fully shut down for several months, but starting around the summer, it did open to 25%, and we're now operating at 50% capacity, which means that most of the really important research is continuing at a pretty good pace at this point. We have access now to all of the facilities and all of the workspaces that we had before. So it's been really exciting for the last at least 4 or 5 months. We've really been able to push things forward and continue with that. And from a clinical research perspective, again, things were challenging earlier last year, but we're also starting to grow in that aspect. We're able to bring some patients on site. And again, things like labs, radiology, imaging, all of that is now open as well. So, so that's exciting compared to a year ago.
Tova, I wanted to emphasize something that Ed spoke about, and it was a point that Dr. Stanton, who's not able to be here yet, but will be later, emphasized in our email exchanges ahead of this, and that is to emphasize to patients who are scheduled for care to get their care, to come to the hospitals. Don't be afraid. As Ed pointed out, the precautions that hospitals are taking are really great. Hospitals are way safer than grocery stores, certainly safer than restaurants. If you go to either of those places, you need care, you should come and get it. That was one of the things that Bob Stanton wanted us to emphasize.
And Dr. Collins, I know that at both of your facilities, I imagine there are patients who are traveling out of state to come see you, and they should talk to each institution about travel restrictions, or where should they look? I imagine there are also patients who are traveling out of state to other institutions. What advice have you for them in terms of making sure that they can and should continue that travel?
Well, we defer to the CDC guidelines, but another conversation that we were having before we got on here that Dr. Boyce was talking about is there is wide variation between facilities as to how they're handling this and managing this. And it's confusing to us, so I'm certain it's confusing to patients. My sort of default, again, are the CDC guidelines, which are evolving and not always clear. But I think they're a decent resource. I don't know what others say.
Yeah, I would say I agree with that. And there are definitely still travel restrictions that are in place. There is significant variability in what the travel restrictions are. And so, you should look at what your local jurisdictions may say, because there may be quarantine requirements, there may be other types of requirements that are involved. Like what Dr. Collins said, we also follow the CDC guidance. I think that is the best evidence-based, objective pieces of information as to what the next steps are. But making sure that you discuss with your local physicians and your team, in terms of any sort of specific patient-specific risks or concerns, is really a valuable way to do this. But as Dr. Collins has said, and I think others have really emphasized, don't delay your care. There are multiple strategies that can be used, either telemedicine or in-person care, and so we want to make sure that you don't get complications that become much more difficult to treat later on because of any sort of delay.
Yeah. I also wanted us to take a moment to address, I know we had in our previous conversation talked about best practices for the entire community, but then also for the FDMAS community in particular. And I think it's worthwhile going over those again because they have changed since we spoke first in April. Can this group advise us on best practices for the general population, but then also FDMS in particular?
I think as a start for the general population, at least starting with continuing to do the hand washing, wearing a mask, outside of the home is really, really important. And making sure that you are maintaining appropriate distance is very important as well. And I think sticking to those things is really the foundation of keeping this pandemic under control at this point.
I would also add that one of the major changes in the past year is really the availability of a vaccine now, and so being able to take the vaccine when that opportunity arises, I think, is going to be an important component of managing COVID, not just within our patient population, but also just in general, across the world.
Yeah, and I think we had talked a bit about in the last webinar about underlying risks and comorbidities and whether fibrous dysplasia McCune-Albright syndrome is something that increases your risk of getting severe COVID. And I think our thinking on this is the same. It's that, fibrous dysplasia McCune-Albright syndrome in and of itself does not appear to increase the risk of getting a severe illness. However, there can be comorbidities of having fibrous dysplasia, particularly in patients that have a high level of physical disability with thoracic FD and rib expansion that may increase the risk of pulmonary disease. So I think all of that is still the same. Vaccine priorities is a real area of confusion for a lot of patients. I do think that patients who have thoracic FD that leads to pulmonary complications, that does constitute an underlying health condition that in many states increases priority to get the vaccine. But I don't think we've had any major changes in that area.
I do see a question about contraindications for any of the vaccines. And it sounds like you're saying there aren't any. Is that? Yes. And there was a question specifically about FDMAS in the rib cage and whether or not that would be an extra struggle with the intense coughing with COVID.
Yeah, so when you have patients who have rib involvement with fibrous dysplasia are at risk to develop rib fractures with even small traumas like coughing. So I think that is something that can complicate a COVID illness. Also, in very severe patients who have involvement of their ribs that either leads to an expansion of the rib cage or maybe a curvature of the spine that can affect lung volumes. And that is a type of patient who would be considered at higher risk from fibrous dysplasia. But fortunately, that is a relatively small proportion of the FD, a small but very important portion of the FD population.
I would add, so I agree with that. And one of the vaccine prioritization is being done at basically at the municipal and state levels. So there's definitely a lot of different structures that are out there. I think it's important to let your fibrous dysplasia or McKeown-Albright's doctor know about your interest, and to coordinate with them as well as your primary care physician to get the documentation that you need, for the prioritization. So working with your medical team is an important aspect of that.
Excellent. Yeah, I'm sure there are a lot of questions about that. So thank you for anticipating that question. Have you any advice over which vaccine people should seek out, or are there any reasons that one vaccine over the other might have an effect on this community?
I think whichever vaccine you can have access to is the one that you should get. They all, of course, there's small variabilities in different ways to look at efficacy in the different studies, but at the end of the day, they're all extremely effective at preventing mortality and severe illness with hospitalizations. So I think that really all of the vaccines are wonderful options. I believe the Pfizer vaccine is the only one authorized down to age 16. So if we have, older teens that are eligible, they should seek that one. But other than that, I would take whichever one you can get.
And some of the vaccine availability is going to be again determined at a different level, so that you may not have a choice. As Dr. Boyce was pointing out, the data from all of the vaccines so far has been extremely good, and all of the ones that are approved, they're assessed for two different ones. One is the efficacy for coronavirus infection, and that does have some variability there. But all of them are between 65 and 95% efficacious in that aspect. But the important part is actually mortality. Is if you get the coronavirus infection, and basically all of the vaccines that are approved have a decreased mortality rate by pretty close to 100%. So that is probably the most important number to keep in mind. And so if whichever vaccine becomes available to you in your region, and if you are able to take it, it would definitely be something worth considering.
Yeah, and for parents of children with this, I mean, even if your child can't get it, it's important for the parent to get it, because every case prevented is the chance to prevent the development of new strains that could evade vaccines. So real important for the non-patient family members to get it who can as well.
Yeah, I've been encouraged by the number of states that have prioritized parents and other caregivers of a disabled population. So if any parents or guardians are caring for children with, or even adults with severe FDMAS with complications, you may be eligible to receive the vaccine.
And they would go about getting clearance for that in a similar manner, talking with their child's care provider and getting some sort of documentation.
Yeah, I mean, I think it depends a lot on whether or not they're classified as under healthcare worker status. So I think it would depend a lot on your local jurisdictions, and I would speak with your primary care doctor about that.
Anything else to add about vaccines? I know that there is, this happened very quickly, and that is incredibly exciting, but it seems like very trustworthy. It sounds like all of them, regardless of which one.
Yeah, and I did want to touch on, because I know that some people had questions about using medications like bisphosphonates for treatment of FD when they're getting the vaccine. And actually the major bone societies have just come out with a consensus statement that we do recommend that treatment with bisphosphonates for osteoporosis. Now, this is a different population than FD, but it's the same medication. So in that population, they recommend that treatment be continued in patients who are receiving the vaccine, but that if possible, it's not a bad idea to just space the infusion and the vaccine administration out by about a week, just so that if you do develop a reaction, it will be easier to tell whether it's to the vaccine or to the medication. So I think it makes sense to also take that into consideration for patients with fibrous dysplasia. But again, we don't want to interrupt care regarding the vaccine. It's important to both get vaccinated and to receive your routine medical care.
I wonder, Tova, if you were getting at in your question before that there may be concerns that things were rushed in bringing this vaccine to the market, and maybe, you know, steps were skipped that would make people concerned. And, you know, I'm not a virologist, but I have been following this. And as far as I can tell, all the steps that we're taking to ensure safety have been followed. That's not the case in some countries. You know, they have skipped steps, but the US very diligently and carefully made the decision not to skip any of those important steps. So I think the safety of these, and it's bearing out because a lot of people have been vaccinated, and we haven't seen any unanticipated safety concerns.
Have you all been vaccinated?
Yes.
Yep.
And I'm eager to get every single person in my family vaccinated as soon as possible.
Likewise.
And I still think it's important also to emphasize that even after you're vaccinated or your family's vaccinated, that, you know, when you're out in public, you still really do need to follow, you know, wear your mask, follow social distancing protocols, wash your hands, just to help reduce the spread to those who have not been vaccinated.
I'm sorry, I'm also reading our questions here. And one person asked, what was the group that came out with the information regarding continuing bisphosphonate treatment?
Yeah, so it was actually a joint guidance issued by the American Society of Bone and Mineral Research, which is our primary kind of bone research organization in the US. The Endocrine Society, the European Calcified Tissue Society, the National Osteoporosis Foundation, and the American Association of Clinical Endocrinologists. So that hits about every single major bone research organization, and I don't think before or since we'll ever see this level of agreement about any topic.
And is that something that we could share after is there sort of a press release for that we could share afterwards?
Yeah, absolutely.
Yes, we can make sure that that's available for folks.
And again, these guidelines are for osteoporosis, but because the medications we're using are the same as the ones we use in FD, although we are using them for a different indication, I think it's reasonable to go ahead and take these into consideration for patients with FD.
Absolutely. So I'm seeing another question. This is, again, we mentioned that different municipalities will have different rules in terms of who has underlying health conditions. And this particular person is asking about the UK, but any place where FD or MAS are not included, they say, I suspect my immune system is not as strong as someone with no medical problems. And I've had problems breathing in the past, and I, feel that because of this, I could be at higher risk. So maybe addressing both, does MAS compromise your immune system first, and then if you do feel, if you have issues with your rib cage or spine, how could you go about that? Even though McCune-Albright syndrome isn't listed, how could you go about addressing that if you feel like you really truly are at risk?
Yeah, that's a great question. I think even though McCune-Albright's as the disease is not listed on there, I don't know, I'm not as familiar with the list that's available in other countries or in other municipalities. Anybody with a severe respiratory condition would be considered at higher risk. And so even just distinct from the disease name, just the respiratory condition is the important part to emphasize. So patients with asthma, patients with COPD, patients like this, where you may have shortness of breath due to chest wall deformities, those would be, in my mind, suitable. And what you would want to do is to talk with your local physician to really get that process documented so that you can get the appropriate I guess, exceptions that would be needed for getting the medication.
Mm-hmm.
In terms of immune dysfunction, there's no known association of fibrous dysplasia or McCune-Albrights with immune dysfunction. But because of these different structural changes, you may be at higher risk of different types of infections or clearing different types of infections. But as an immune disease, fibrous dysplasia and McCune-Albrights would not be considered as like an autoimmune or an immune dysfunction disease.
I'm also seeing a question about AstraZeneca. Are you able to comment? I know there's no virologist here. Are you able to comment on AstraZeneca at all? The AstraZeneca vaccine, which has been, approved in some countries, although I believe not in the United States at this point.
Yeah, I'll confess I'm not very familiar with that vaccine because it hasn't been approved in the US yet. I haven't been following it as closely. Anybody else?
I know that there was information recently that some countries, I think including Denmark, has temporarily held because of an potential increased risk in blood clots. I think the European Medical Association has issued a statement saying that they did not recommend suspending it because that they did not see that as a higher incidence. They felt that that was related to just the comorbidities. These were patients, I think, that were older than 80 that they were seeing these complications in, and so that there were other reasons that might be contributing. But I think as Dr. Collins was pointing out, the vetting process for these medications is very strict, not only within the EMA and the FDA, but there's also a lot of post-vaccination follow-up that is going on. And so, the question that I think people should be following is really, making sure that, I think all of these agencies are being very diligent about following the safety of the vaccines. But certainly so far in the large numbers of people who have been receiving the vaccines, it's been extremely well tolerated. Like any other medication, and pretty much anything else we do, there's always risks. And if you are somebody who has a particular medical condition that you feel may put you at higher risk, that's something again to discuss with your physician as to whether the vaccination or that particular vaccine may or may not be appropriate for you. So.
Sounds like still really important to be in communication with your doctor about any of these vaccines. There was a follow-up question, Dr. Hsiao, about what you had mentioned earlier about some being at higher risk for some kind of infection. I think this was in regards to talking about McCune-Albright syndrome and the immune system. Can you speak more to that?
Yeah, so just to clarify, it's the immune system in patients with fibrous dysplasia and McCune-Albright's does not appear to be affected, so it appears to be normal. The parts that put people at higher risk of like respiratory infections is what like Dr. Boyce was mentioning, is if you have rib lesions or you have involvement of the chest wall or of the spine. For example, you may not be able to cough as well and clear the secretions out, clear out, infections, and that may put you at higher risk from that particular standpoint. So the immune system and ability of the body to fight off infection is not changed, but there may be physical changes that contribute to an increased risk.
This might be a question that Dr. Stanton would best be able to answer, but I imagine any of you could address. How about patients who don't have those particular areas affected, but maybe are just recently post-op? Are they at higher risk? Should they be considered differently as they can take the vaccine? Those post-op, that post-op period when you are sort of still healing.
To my knowledge, I don't believe that there's any changes around the guidelines, based on, being post-surgical. Certainly, I think it'd be really important to, make sure that you're following, all the right precautions in that period. But that doesn't typically change the, the eligibility for vaccination. I know before, folks go to surgery, they do test to make sure that you're not actively infected with the coronavirus, which is really important as well. And making sure that the caregivers that you have that are taking care of you are also following precautions as well.
I'm just reading up on the Astrazeneca vaccine hours ago.
You're very honest to admit.
Well, you can tell us,
story
if
was-
I got that right. So
No, you did, but apparently very recently, the story about the clots has been put to rest.
okay.
So I don't think it makes it. But the fact is, we manufactured millions of doses of it here in a factory here outside Washington, and those doses are sitting, waiting for FDA approval. So I don't know what the holdup is in the FDA approval. But anyway, so I think the story about the clots has been put to rest, it appears. But it's still, there's some questions remain, it sounds like. AstraZeneca to seek FDA approval within weeks, March 8th.
So Tova, I don't know if there's any, oh, sorry, go ahead.
I was going to say, from what I was seeing, the preliminary efficacy looks really good, like the others. I don't know what the issue is over safety or efficacy or manufacturing or what, but I mean, just the fact that it's being held up while millions of doses are sitting around just speaks to the fact that the agencies are being really careful about this. I don't think bad stuff is going to get on the market.
Tova, it doesn't sound like there had been any questions about potential side effects of the vaccines or sort of symptoms around vaccines, but I think it's really important to address that because I know families and friends for sure are often asking this question. So for the Pfizer and the Moderna, it's a 2-series vaccine, and it's not uncommon to experience either mild fever, some chills, sometimes muscle aches or joint aches. Not dissimilar to what some people can get with the influenza vaccine, but with these mRNA vaccines, that response can be much stronger and is a sign that your immune system is activating and responding to the vaccine. And so I think making sure that people are aware of this ahead of time so that they can sort of expect it and be prepared is really helpful. Yeah.
So I think what you're saying is that if you feel flu-like symptoms, you're feeling a little sick afterwards, that's normal, and really the vaccine is to help. You're having a much less severe reaction than the actual illness would be. Is that something
correct?
Absolutely. Yeah.
Absolutely, and most people's symptoms, don't extend too much beyond sort of the 24 to 48 hours. So, oftentimes we'll counsel people, consider maybe taking the next day off of work just in case, you do feel a bit under the weather, so you can be prepared for that, and you're not trying to work when you're not feeling great. But most people do just fine after that 48-hour period. And I believe that the CDC is now saying that if you do develop symptoms after the vaccine, the muscle aches, the joint aches, that it is okay to take a little bit of like an ibuprofen medication afterwards.
On the flip side of that, should I be worried if I have the vaccine and I don't have a reaction like this?
So that's a great question. So some people don't, and actually many people don't after the first vaccine, but then get it after the second vaccine. And so I think there's a wide range of reactions and symptoms that people have afterwards. So no, I wouldn't be worried about that, particularly not after the first one.
Before this, we did have some questions about, because I believe last year we were recommending, or many facilities weren't seeing patients unless it was a medical emergency, or they were scheduling many more telehealth visits. And And you addressed this really near the beginning. That seems like most hospitals have returned to, most providers have returned to seeing patients in person, and recommend continuing care on a regular schedule. Is there anything else to add to that?
No, I think that telehealth is something that really became very, very common very quickly when the pandemic started, and now I think most hospitals are doing a combination of telehealth and in-person visits, and it's been kind of really interesting to see how it's made us rethink what type of visits are important to have in person and what type of visits can possibly be done with telehealth in a more accessible way. So something that has probably changed the landscape of medicine, possibly forever. So so I think that having in-person visits certainly should continue for some things. I think Dr. Stanton particularly wanted us to emphasize that many visits with surgeons are not optimally done with telehealth because the physical exam is such a critical component of that visit. For other fields, specialties such as endocrinology, sometimes we can space out the in-person visits a little longer and do telehealth visits in between. So it's really specialty dependent, and important to check with your doctor about, how crucial is it to come for an in-person visit versus telehealth.
Mm-hmm. I'm seeing a question about the one-shot vaccine versus the two. And especially as regards to symptoms afterwards, but I know that's a question that I have about whether there's any, should I be wary of the one versus the two?
No, I don't think you need to worry about whether one is a two-shot system or a one-shot system. They are basically manufactured using different strategies, or they work by different strategies. And the main thing to keep in mind is that regardless of whichever strategy is used, the ones that are approved have been shown to be efficacious. So either one of them would be fine.
And you could expect similar symptoms in the one-shot vaccine, the aching arm, headache, some fevers.
Yep,
just
exactly. Yeah, and you have to remember that these reactions, as Dr. Wentworth was describing earlier, is that these are vaccines. These are side effects that are seen with other types of vaccines too. So anybody who's had a child who's had to go for any of their regular vaccines knows that the very similar types of symptoms show up. So.
I'm also seeing there's lots of questions about non-COVID related specific, and we really are, we will be providing more programming. If you have a question that's not specific to COVID, I encourage you to reach out to us and we can try to give you resources in regards to your question. There are some questions about Denasimab specifically and the research, the ongoing research regarding that. So perhaps Dr. Boyce, you can address that.
Sure. So Denasimab is an inhibitor of rank ligand. It's used to treat osteoporosis and some other types of bone tumors. And there's been recent interest in potentially using it to treat fibrous dysplasia. We do have an ongoing interventional study of Denasimab treatment at NIH, and that has been able to move forward during the COVID pandemic with some restrictions. We have had to kind of slow down recruitment at certain times. We've had to make some modifications to this study so that some of our visits are done via telehealth, but that is fortunately moving forward.
That's great news. With the slowdown, do you have I think an anticipated timeline when we might have something published from that? I think in this community in particular, it's very exciting to have a vaccine for COVID-19 in a year, and of course, this community in particular is hungry for more answers all the time.
Yeah, no, we're getting close to being done enrolling for that. We only need actually one more subject to enroll in that study. And then, so hopefully within a year, we should have some preliminary data about how patients are responding to treatment. A really important part of Denasimab is not only how do you respond to treatment, but how can you safely stop the medication? What happens after that? So this study has a very long period of monitoring after Denasimab is discontinued, and that may take a little longer to find out. But of course, we are committed to sharing as much information as we can while we go, and certainly happy to update the community as we know more.
Thank you. Okay, I'm seeing another question about, I think because we've indicated that this is a risk factor, the rib cage and spine, somebody worried, you know, the fear that if they cough so hard, they fracture a rib bone and puncture a lung. Have you ever seen anything like that? Do you think that that's something to be concerned about?
It's not something I've personally seen in patients with FD. I think any patient that has really severe FD rib involvement can tell you that rib fractures are something that can happen commonly. Fortunately, by far and away, the most common type of rib fractures to see in FD are what's called microfractures. So they're just very small areas of fracture within the bone that sometimes you can't even see it on an x-ray. It's so small. However, it can be very, very painful, but it's not something that's going to cause a big, you know, anatomical change and have like a piece of the rib come in and puncture the lung. Lung punctures can happen with rib fractures, but the most common scenario I've seen that in medicine is something like a car accident or a really huge trauma that causes a big fracture. So I don't think it's
bigger than a cough.
too much. Oh, much bigger than a cough, yeah.
Yeah, I've never seen or even heard of a lung puncture happening with a rib fracture in FD.
Just scanning here for our questions, making sure. I think I'll continue to watch to see if any other further questions come in, but I'd really like to just wrap up by going back and emphasizing some sort of large takeaways. You know, maybe each of you could pick one really important thing, really important takeaway that you hope people walk away from this conversation. With Dr. Boyce, do you mind starting us off here at the top of my personal screen here?
Sure. So I think by far and away, the thing that would most benefit the health of the FD MAS community is to get vaccinated. I would really, really encourage people to get the vaccine as soon as they're able. I mean, it's important to protect both the patients themselves and just our society at large. So please get vaccinated.
Whatever the vaccine you're offered or is available.
Soon, this first one that can get in your arm is the one to get.
Great. Dr. Collins.
I would say, as has been said, just to continue, I think Kelly said, just continue following guidelines of masking, social distancing, follow the CDC guidelines. I know local guidelines can vary widely, and that if you're someone who has a condition like this, you probably need to be a little bit more careful. And there will probably be people in your community who aren't being as careful, and stick to your guns, follow the recommendations, don't get in arguments, just do it.
Thank you. And Dr. Wentworth, do you have anything additional for this community?
I think the most important points have already been raised, so I would just emphasize those. And I think in addition to getting yourself vaccinated, encouraging those around you when it's their turn to get vaccinated as well. Even if you're not up there on the list yet to get vaccinated, encouraging those who are to get vaccinated. And I think just maintaining contact with your FD, MAS or PC or primary care physician during this process as well, so that you don't miss appointments. And as we've been discussing, telemedicine telemedicine has really advanced during the pandemic. And I still do a lot of my visits through telemedicine. So if anything comes up, that can always be arranged. And then, in-person visit can be arranged after that. But, trying to stick with the, the routine appointments so that your physicians are updated.
And then, Dr. Hsiao, would you mind specifically addressing just being the last one on my Zoom call? I'm putting it on you to emphasize again about the high risk, who in the FDMS community, if anybody, is considered higher risk.
Sorry, yeah, so the basically patients in the FDMAS community who have sort of rib involvement or difficulty with breathing, shortness of breath, rib involvement, spine involvement, would be considered higher risk. And I think that's important to coordinate with your physicians and to make sure that both appropriate care is given, as well as being eligible for the different vaccines. And I think one of the other things just to really keep in mind is that there are a lot of people who are talking about vaccines and coronavirus and COVID and what is probably the best thing to do is to really stick to sources that have really strong reputations, have really thought about the consequences and the disease. And so, the CDC, the EMA, the FDA, I think many of these organizations are really dedicated, their main purpose is to protect human health. And those are excellent resources. They have really well thought out guidelines and, using those as the resources to decide how you care for yourself as well as, the people around you and your community, I think is really important.
Thank you. And I did include the CDC website in the chat. We'll pin that so that's available. Are there any other major points that, or takeaways, important takeaways that we missed in our quick rundown here?
I think the one thing that Dr. Stanton had emphasized, that is if you're scheduled for something at a hospital or clinic, get it done. I think this is especially true for surgeries, is get it done. It's a safe place. Don't put it off. You will incur more problems if you put it off than if you go ahead and get it at the time it's scheduled.
Yeah, I think Dr. Stan was particularly wanted to emphasize that in children with FD who are still growing, there can be, real time points where things need to be addressed. So especially for our pediatric population needs to continue with their care.
And maintaining communication with the medical team, both either through the in-person visits or telemedicine, or even just checking in now and then. I think the medical team is there to help you, and can provide if there are sudden changes in coronavirus in your particular community that may change whether or not you can come on site or something like that. Those are the people who would be able to help give you the best guidance to make sure the FD and MAS is managed.
Yeah, I'll share that I've had success. I know it can be as simple as through your electronic medical record, sending a message to your care team to address any of these questions locally. I think it sounds like is a good idea. And somebody on your care team can get back to you. Excellent. Anything else before we wrap up here? Great. I'm very grateful to this team of experts for giving their time and their expertise in answering these questions. If you had questions that we weren't able to get to, I really encourage you to reach out to us via info@fibrous-dysplasia.org, and we'll do our best to connect you with resources. And we will share this afterwards so that it's available for folks. We'd love for you to keep up with the Alliance and our upcoming activities. You can always visit our website, fdmasalliance.org. We will soon be launching our $1 Million Bike Ride initiative. This is, you can join Team FDMS in the UPenn Orphan Disease Center $1 Million Bike Ride. It does not actually involve any commitment to ride a bicycle, but it is a really powerful way to the community to raise funds for FDMS research. And as I mentioned at the beginning of the call, Dr. Wentworth is an awardee from 2018 who's been able to continue on with her work. So please be on the lookout for more information about that. And with that, again, I'm very grateful to this team of wonderful experts for sharing their time and their talent with this community. And be well, everybody.
Thank you.
Thank you. Take care. Stay healthy.
Thank you.
Bye-bye.
Bye, everyone.